Hi, everybody. I'm John Reagen. As Dr. Kramer said, I'm a third-year student here at KCU Joplin. And the article I'm presenting today is Duration of Cardiopulmonary Resuscitation and Phenotype of Post-Cardiac Arrest Brain Injury. I found this article in my emergency medicine rotation, and considering I'd like to go into this field after graduation, figured it'd be a great article to present. So without further ado, let's get started. This slide is a little bit about me. This is a picture of my family on the right. This is my mom and dad, and my sister, who is actually a fourth year here at KCU and did a presentation about adenomyosis not too long ago. At the bottom is my church, and that's me playing guitar way in the back there. These are my two dogs, Pepper and Bella, and this picture in the middle is all of us from Thanksgiving. That's my cousin and her husband, and then another medical student from class. So let's do a brief introduction about how today is going to go. There's a lot of things to explain in this presentation, so instead of giving you a mini lecture at the beginning and just hoping you remember it all, I'll just explain as we go along. First, we're going to talk about cardiac arrest and CPR. There'll be some background information about the study and foundational information to understand what's going on. Touch on the methods and statistical analysis that was used in this study, as well as the results. Finally, I'll talk about the discussion points that these authors had, as well as the limitations of the study. So let's get started. So the American Heart Association and the American College of Cardiology defines cardiac arrest as a cessation of cardiac activity so that the victim becomes unresponsive with no normal breathing and no signs of circulation. This results in a loss of blood flow to vital tissues, the most vital of which being the brain. It's commonly divided into two different categories: in-hospital cardiac arrest and out-of-hospital cardiac arrest. Unfortunately, this is a very common cause of death, with over 400,000 people dying of cardiac arrest every year. To put that in perspective, that's the entire city of Tampa, Florida, every single year. CPR, cardiopulmonary resuscitation, is the best option we have when dealing with cardiac arrest. As a brief refresher, here's how it works. Chest compressions are performed 100 to 120 times per minute, at least 2 inches deep, the goal of compressing the chest downward, pushing blood up to the brain. Rescue breaths, when safe for the responder to do so, are recommended but are not required for a successful resuscitation. Studies have found that even with proper CPR technique, the perfusion rate to the brain is only up to 40% of normal blood flow. So, despite it being the mainstay of care during a cardiac arrest, it's clearly just buying time. This is one of the many factors that lead to CPR having a very low survival rate to hospital discharge, with out-of-hospital arrests only having a 9% survival to discharge rate. So we know that CPR definitely helps, but other than the perfusion, why are survival rates so low? Well, firstly, our brain's just not meant to go without oxygen. After only 3 minutes, we're looking at permanent brain damage. In addition to this, patient comorbidities can make post-resuscitation care very difficult. Recovering from an arrest is already a very difficult and stressful process for the body. So if your body is already stressed with functions of daily living, it makes it all that much harder to recover. Then the cause of the arrest is an important cause. As you can imagine, penetrating trauma to the chest would be harder to recover from than other causes. Then lastly, there are two factors that I'd like to talk about. There's the duration between arrest and the start of CPR. We'll refer to this as no flow time, and it'll be become more important a little bit later. And then the duration of CPR, which is today's topic. That brings us to today's study. It's called Duration of CPR and Phenotype of Post-Cardiac Arrest Brain Injury. It was authored by the University of Pittsburgh and published July of this year in the journal Resuscitation, which is the official journal of the European Resuscitation Council. Among the disclosures, ethical approvals, and other miscellaneous statements, the article preemptively noted that one of the authors on this study is on the editorial board for this journal. I don't believe that affected the quality of the data in this article, but I'm sure it affected its chances of getting published. The purpose of this study was to determine how the length of CPR affects the type of brain injury. So we all know that longer CPR times result in worse outcomes, but they would like to see what this looks like clinically. Before we go any further, let's define some common terms that will come up. The brain injuries described in this study are called hypoxic ischemic brain injuries, which are caused by insufficient oxygen and blood flow to the brain. There's a non-malignant coma, which is a comatose patient with neither cerebral edema nor BSIV. I'll define those in a bit, but all you need to know for this is that a non-malignant coma is just a regular coma. Cerebral edema is a general term for an excess of fluid in the cerebrum. In this study, the criteria to meet cerebral edema is a gray to white ratio, or GWR, of less than 1.2. This GWR is calculated by looking at a CT scan and calculating the ratio of gray matter, as shown by the blue arrow, to white matter, as shown by the red arrow. This level of edema of under 1.2 shows destruction of gray matter and is predictive of a very poor neurological outcome. So cerebral edema can happen through many mechanisms, usually about 5 different ones, but with regard to cardiac arrest, there tends to be just 2. There is a vasogenic mechanism, which is caused by a loss of function to the blood-brain barrier. Normally, you have tight junctions between cells, as well as the supportive cells of the central nervous system, providing that barrier to the brain. When this gets disrupted, it allows proteins, ions, consequently water, to enter to the brain. This results in an excess of extracellular fluid. Second mechanism is caused by acute cytotoxicity from ischemia. This causes damage causes failure for ion pumps, which normally keep sodium outside of the cell. When this pump fails, it causes a reversal of sodium back inside the cell, leading to an increase in intracellular fluid. Considering both of these mechanisms occur at the same time, you end up with too much intracellular fluid and too much extracellular fluid, leading to further brain injury. Burst suppression with identical bursts, or BSIB, is an EEG pattern distinctly seen in comatose patients who had cardiac arrest. This condition is typically unresponsive to typical anti-epileptic medications, and it's been predictive of poor patient outcomes. This condition has an exceptionally low false positive rate and is nearly pathognomonic of having a history of cardiac arrest. Because of this, it makes sense why it was chosen to be a phenotype for the study. Here's a picture of a normal EEG, and this is a rabbit hole I could spend all day exploring, but all you need to know is the stark difference between what we see here and what the next slide will look like. So this is what normal is. Typical burst suppression looks like this, where you have a period of activity, and then a cessation of brain activity, which is the suppression of the burst, then a return to normal activity. So that is burst suppression. And burst suppression with identical bursts is seen in these examples. In all 3 of these examples, the burst suppression was cut out so that way you can better compare the character of bursts. These arrows show that the character of the burst is identical, hence the name burst suppression with identical bursts. So now we can finally talk about the study. This study looked back at 10 years worth of data from the University of Pittsburgh's own database. It looked at all adult cardiac arrests, both in hospital and out of hospital. There was a little bit of exclusion criteria, with a total of 281 people being excluded for 3 main reasons: a neurological or traumatic cause of arrest, being admitted to the hospital over a day after a cardiac arrest, and those who died prior to admission. This left a total of 2,440 subjects for the study, which is just phenomenal. Then, each patient's CT and EEG data, when available, was analyzed to create a phenotype. And in this study, there were 5 different phenotypes: the awake, non-malignant coma, BSIB, there's BSIB and edema, and then finally, edema. With their cohort information complete, they created this table, which is very large. There's a lot of information here, but the important data points for our discussion are in these boxes. Up at the top here, you have the different phenotypes. As I said, you have 1, 2, 3, 4, and 5 phenotypes. In this second box, you have the total CPR duration, as well as the amount of missing values. I'll touch on this a little bit later when we discuss the limitations of this study. Then at the bottom, you have the amount of CT and EEG scans obtained. as well as the total gray to white ratio for each category. So in addition to these, we see some blue boxes come up. At the top here is some general demographic data. But one thing that I found interesting about this is the male to female ratio. About 40% of people in this study were of the female sex. And as you know, males and females can present differently for different conditions. The best example of which being a heart attack. Females tend to present differently than males. So having a very good split between male and female can show that these phenotypes either have a significant difference between sexes or is a rather universal correlation. Then at the bottom, we have our survival and outcome rate. So this study did better than average in terms of its survival, with 37% of participants surviving. And at the bottom here is their prognosis. This CPC is a cerebral performance category, and the first two categories, 1 and 2, denote the ability to function independently or near independently outside of a hospital. So unfortunately, of the 37% of patients who survived to discharge, only 11% of these people still had the ability to function independently outside of the hospital. So what did they do with all this information? Well, CPR duration was plotted on a graph for each phenotype, and then local regression was performed to predict the probability of phenotype as a function of CPR duration. The unknown amount of no flow time was a big limitation for this study, and so the authors tried to correct for that as best they could by restricting this to out-of-hospital arrests that were witnessed in the field, to try and minimize that amount of time done without cardiac arrest, without any CPR. They also corrected for some missing values in the data sets through something called multiple imputation. We'll talk about this in a few minutes. So while you saw that their data set was rather comprehensive, it was not complete. There are missing values for several different categories, including the initial rhythm during arrest, the number of epinephrine doses given, the number of defibrillations or shocks given, some of the gray to white ratios for CT images that were not easily interpretable, and the duration of CPR. Personally, I'm a little surprised that some of these values were not exclusion criteria, especially since the study is about duration of CPR, but I'll talk about that during the limitations section. So how did they deal with these missing values? They used multiple imputation to attempt to fill in the gaps. In statistics, imputation is using different values, for example, the mean, median, or mode, to fill in missing values and create a new complete data set. Multiple imputation is using imputation to create multiple new data sets. So one data set with one different data set, each estimated value. So while a data set may have a normal distribution like this in the middle, where the mean, median, and mode are the same, it may look like this on the right, or like this on the left, where the mean, median, and mode are 3 different values. And so you can see how with each factor having its own distribution, the amount of new data sets can pile up very quickly. This creates many different data sets and reduces possible inaccuracy that you could have by just using a singular value. So we can see how multiple imputation affected the data set here in this table that I made. In the second and third columns, we have the before and after imputation value, as well as the amount changed from each value. The biggest change you can see is the non-malignant coma category. This is by far our most popular category. You can see it went from 53% of its total patient population to under half, only 40% of the patient population. So you can see how the imputation affected this data set. So this is a table of the results. It's, again, very large, so I'll boil it down to what we need to know. So the data came out to over 2,400 subjects, which, as I said earlier, is just great. As you know, larger data sets are better for demonstrating correlation. The median subject age is 59 years old and a very good 60-40 male and female split. Over 75% of these patients arrested outside of hospital. And in this study, that includes having an arrest in the emergency department. Going back to our regression, The only ones that were counted into regression were those witnessed as out-of-hospital cardiac arrests. So with 29% of these out-of-hospital arrests being unwitnessed, that means that nearly 30% of patients were excluded from the regression. This hospital system did better than average in terms of survival, with over a third of their subjects surviving until discharge. So let's look at these results visually. As we've seen in this, as we're going to see in this, as the cumulative duration of CPR increases, then the likelihood of a phenotype, of a worse phenotype presenting, also increases. What I like about this graph is that you can see the overlaps between different phenotypes. At the beginning, the awake category is mostly compiled over here, whereas the cerebral edema category can start as early as the beginning of CPR and stretch all the way to the end. The most interesting overlap I'd like to bring up is the difference between the awake and non-malignant coma category right around this 10-minute mark here. And so why do we care where these overlaps are? Well, this sets us up for future research. So we can start to tease out why in some patients who received 10 minutes of CPR, they were awake, and why others were in a non-malignant coma. So there can be many reasons why there were different outcomes, such as comorbid conditions, the duration of no flow time, some influencing factor inside the hospital, or something else entirely. When we do further research, we can start to piece together the puzzle and be able to better predict patient outcomes. This next figure shows the data a little bit differently. On the x-axis, we have duration of CPR, like we did in the previous figure, but on the y-axis, we have the probability of each phenotype occurring, so 60%, 40%, etc. So why does it look like a paintbrush made this graph? This is where that multiple imputation comes in. Each line inside this paint stroke is its own data set, mathematical model filling in those missing values. And so you can see how the uncertainty in these data sets affects the probability shown. In the awake category, there's a rather low level of uncertainty across the entire curve, but the uncertainty for other phenotypes gets so big that it blends together, as seen with this non-malignant coma and BSIB category. While figuring out the cause of the overlap is out of scope for this study, it does show the limitations of the data set. It can more efficiently guide future research. After seeing the results, here are some discussion points brought up by the authors. As we saw, there's significant overlap among different phenotypes, showing us that even at longer durations of CPR, there's still a chance of less severe brain injury. And the opposite is true. Even at small amounts of CPR, you can still have a very severe brain injury. Next was the idea of prophylactic osmolar therapy. As we saw, edema can begin right away with arrest, so there could be merit to promptly beginning measures to decrease the chances of edema. Then the limitations of the study were discussed, which I'll touch on in a minute. So what is osmolar therapy? It's a treatment that aims to decrease intracranial pressure caused by edema to mitigate any further damage. There are typically two options for osmolar therapy. First is mannitol. It osmotically draws water out of cells into the extracellular space, leading to a decreased intracellular volume. It also stops sodium from being reabsorbed by the kidney, leading to a diuretic effect. This is great for patients who are fluid overloaded, but it has been shown to lead to hypotension. Next is hypertonic saline, which draws water out of the cell, similar to mannitol, and into the interstitial or intravascular space. However, contrary to mannitol, there's no diuretic effect when using hypertonic saline. And this makes it preferential in any cases where resuscitation is either needed or expected to be needed. Let's discuss the limitations of the study, the most obvious of which being missing data points. This is just a cropped version of the large table that we saw earlier. As a bit of an homage to Dr. Staudinger, these bounces are going to bounce into the view, so that way we can draw our attention to some of the important pieces of missing data. Considering this study is about CPR duration, as I said earlier, I'm honestly surprised this wasn't an exclusion criteria for this study. Next is the amount of patients that did not receive a CT scan. Only 2/3 of the subjects in the study received a CT scan. And considering you only have CT imaging and EEG being your diagnostic studies, I think that would be important to try and get that number as high as we can. Then there is the EEG. percentage, which is the lower of the two. Again, this might not be as important, like I don't think you would really need an EEG in the awake category, but considering it's the only difference between your non-malignant coma and your BSIB, it would be best to try and increase this number as quickly as possible. So considering this study looked at existing data from a database, addressing these limitations requires a little bit of foresight and a little bit of expectation of future studies. It can be difficult to order what might be considered unnecessary studies, especially with CT imaging being a radiographic study. But if there's proper patient consent and proper ethical concerns addressed, it could be addressed in the future. There are some other limitations that the authors describe. There is possible human error of those who reviewed the CT scans, which could result in misclassification. This study only collected hospital data from one system in one region of the country. So there could be differences in demographics and standards of care in different areas around the country and around the world. Next, of course, is that all of these cases are very complicated patient cases. There are a lot of factors that go into this. Next, there is no data about CPR quality and no data about the duration of no flow time. Both of these directly influence the duration and degree of hypoxia. As you can imagine, if the chest compressions are of poor quality, less blood is circulated, resulting in more hypoxia. Even worse, as the name implies, no flow time is the duration of no flow to the brain. CPR duration in this study is essentially being used as a stand-in for the duration of hypoxia. So the longer CPR is performed, or the longer insufficient compressions are performed, the longer the brain goes without the oxygen that it needs. So this shows how these last 2 points are especially important when considering that the CPR duration is just a stand-in for hypoxia. So the conclusion of this study is that the phenotype of post-arrest brain injury is related to the duration of CPR. Why do we care? The authors state that it has implications for clinical design. As I talked about earlier, we can tease out the reasons why there are different overlaps between categories, and it is very good for prognostic data. It could become a rough indicator for the outcome of the patient, and it's very important that either the patient or the next of kin has some idea of what to expect. It's best seen in the field of oncology, where one of the first questions after you receive a diagnosis is, well, what's going to happen? How long do I have? What does the rest of my life look like? The ability to have this prognostic data after an arrest would better inform either the patient or next of kin to make more informed decisions regarding further care. In addition to prognostic data, this could become an indication for prophylactic osmolar therapy, as I talked about earlier, especially for patients who are likely to develop cerebral edema. Patients who undergo CPR for extended periods of time could be preemptively started on such therapy to decrease the incidence or severity of the edema, thereby reducing the extent of brain damage and improving patient outcomes. That concludes my presentation, and I'd be happy to try and answer any questions you have.
Okay, thank you very much, student Dr. Reagen. That was a really nice presentation. Your figures were great, and your presentation style was right on. So I see Dr. Gordon has her hand raised, so I'll start off the questions with Dr. Gordon.
Thank you. Excellent presentation, very concise. I apologize, I had my video off, but I had to eat my lunch because it was my only chance to do that.
I get you.
So question I have, I didn't catch the study design. So was this observational?
So
this and just at one point in time?
This looked back at, let me back up for you. This looked at all of the data they had regarding cardiac arrest back from January of 2010 into January of 2020. So they used 10 years of already existing data. This study was done, it was published this July, and so they were working on it in the past few years. But they pulled existing data. They didn't influence any variables amongst there was no active portion of the study. This was just a retroactive look.
Okay, so what would you call that study design?
retrospective, I imagine.
Yep, it is retrospective. Without like seeing the paper, it's kind of hard for me to see how because they compared like 4 different groups, right, with different outcomes.
They did.
Yeah. So did they do any analyses using one of those groups as like a reference group for the other groups?
No, they didn't. So all they really did was categorize it into the five phenotypes, and looked at the outcomes and also just how that correlated to the time. Their main goal was just to see how it looked clinically, because they say in their paper, it's a rough quote, but that we all know that longer CPR has a different patient outcome, a worse patient outcome, but we want to figure out what that looks like clinically.
So that kind of made sense to me as a no-brainer, right? Without doing the study. But what I would have asked myself, or if I was doing the study, I think I would want to know what are the comorbidities, like what are the characteristics besides duration of CPR? There could have been some other types of variables that would be intervening with the outcomes, correct?
Correct. And I think that was kind of something they were looking at as something to build off of in the future. They said in their article that, this doesn't make any like groundbreaking, discoveries in terms of patient treatment, but it does set up a lot of further research. And that seems to be kind of their main goal, as laying foundations for others to build off on. Because like I said, these are all, really complicated patient cases. And so it could set up a lot of future research as to what caused those different outcomes.
And I thought I heard you say, but I could have misheard. Did you say something about a regression analysis or some sort of analysis that they did? What kind of analysis did they do?
So they plotted each phenotype for the CPR duration, which was this graph. And then they did do a regression using the multiple imputation values that they
That's what I thought you had said. Okay. But when they did the regression, they didn't include all those other variables. They only included certain variables, right?
Correct. They only included the CPR duration and phenotype.
Yeah. So I guess my question overall is, how much do you believe these data? Is the sample generalizable?
And that's what I wonder. There was, looking back at the missing values, I believe it was, depending on which phenotype, 8 to 9% of them did not have a total duration of CPR value. And so considering that's the main variable in this study, that means, there's 8 to 9% of your sample size is just being guesstimated. So that's definitely a big limitation. And as I talked about, it's just really a duration CPR is a stand-in for hypoxia. So if you have a patient who has, lung issue, COPD, any other perfusion issue, then it would complicate their case moving forward. And so that might be one of the variables that changes, their phenotype at the same CPR duration.
Yeah. And in terms of the sample, so this was a single hospital in Pittsburgh, right?
Well, it was a single hospital system. Yes. So it wasn't the one building, but it was just all in the same area. Yes, ma'am.
Oh, so it was the system?
Yes.
Like downtown Pittsburgh?
Yes, it was the University of Pittsburgh hospital system. They didn't go into detail how many systems and across what area, but they did bring up that it's mainly just that Pittsburgh area.
Okay, so that was my question about generalizability of the sample as well.
Yes, but considering this is a, I guess, rather simple setup, I think it does lend itself to being easily repeatable, or at least retestable with existing data, considering it takes numbers that are already there and runs basically it's just an analysis of existing data. I think it would lend itself to being repeated across different parts of the country, West Coast, Midwest, etc.
Well, I mean, the other thing, I don't know, I'm not a fan of retrospective studies, as you can probably tell. So where do they fall on the hierarchy of evidence?
I can't answer that personally, but I'd imagine it falls pretty low in terms of having impact on current applications. But it does seem that it might be able to just lead to some further research, or maybe inspire people to do a more ongoing clinical study. Instead of having a retrospective, maybe start doing live studies with people.
Yeah. So the last thing, I'm sorry, I'm asking all the questions, but one of your last comments was there may be a role of the osmolyte therapy.
Yes.
So are there any downsides to doing that preventively? Because your outcome of cerebral edema or any of those other things, that's seen after the fact, right? After
Yes.
imaging. So at the beginning, when CPR is started, because that's going to be started before there's any imaging or diagnostic tests done, would there be any downsides to having that osmolar therapy as a preventive agent?
There could be, and it also depends on a lot of those comorbidities. So, like I said, with mannitol, it's a diuretic. So if somebody isn't fluid overloaded, they aren't hypervolemic. It could cause hypotension, which is the last thing we want in any resuscitative scenario. Hypertonic saline, since it has a lot of sodium, it could cause too rapid overcorrection of a hyponatremic state and cause osmotic demyelination. Or if they're already hypernatremic, it could push that further and cause more damage. So it depends. I'm sure there would be, some sort of candidate for prophylactic therapy, but it is not without its risks. And then in addition to it, you are adding volume to the circulatory system. So if somebody does have, congestive heart failure or something, where they're in a chronically overloaded state, which could lead to cardiac arrest, I'm sure it's rather common, it might not be the best choice.
Okay, thank you.
You're
I appreciate the presentation.
Thank you.
Yeah, student Dr. Reagen, I've got a couple questions for you. So at the beginning of the talk, you mentioned that, and this is just paraphrasing, CPR is kind of the best tool in cardiac arrest.
Yes.
Is it better, and this is just because of my lack of knowledge here, but is it truly a better tool than, say, the AED to try to shock the heart back into rhythm or to restart the heart? I noticed that they did mention that as, one of the things they looked at in their table was something about shocks. So go ahead.
So it's actually a combination. So not all cardiac arrests are shockable. It depends on the presenting rhythm. Ventricular tachycardia and ventricular fibrillation are the two rhythms that can be shocked. So if somebody has no rhythm at all, it doesn't do any good to shock them. But in any setting where there is cardiac arrest, CPR is performed. So even if they do have a shockable rhythm while you're waiting for the AED to charge up and sense rhythm and whatnot, as you're running that code, you are performing CPR. So it's one of the only treatments that is included in every cardiac arrest. And of course, this can be augmented with different medications. Paramedics come or doctors come, and epinephrine, amiodarone, other medications, but CPR is performed with every single cardiac arrest.
So it was kind of hard to see on the table that you presented, but it looked like those that did have the shock, it was pretty low in terms of percentages.
Look at that. Yeah, and they collected a lot of information in the study that they didn't seem to end up using, which kind of confused me a little bit. Like they used the multiple imputation for epinephrine and initial rhythm and whatnot, and then they don't touch upon it any later. So I'm not even 100% sure what they used that imputated data for. I don't know if they were running another study at the same time that did something different with that, but even then, why would you bring it up?
So I see rescue shocks. It only
Yes,
looks like 2% total had. No, that was missing. So 2% missing.
but yeah, it seems like nobody really received rescue shocks. So I don't know if whether that's due to the presenting rhythm, but it doesn't seem to be the case, as a third of the patients had a shockable rhythm. It might be due to availability of defibrillators. Maybe they were resuscitated before paramedics got there and were able to take care of the patient. That was one of the things that I found interesting. They collect a lot of this data and then don't really do anything with it. Like none of the
Sure.
ethnicity. I mean, it's nice to have, especially if you're going to use this for future studies, but there's a lot of stuff they don't really do a lot with.
So my other question, and this is more I'm looking kind of for your opinion on this because they don't seem to touch on it at all. But I know when I was young and trained as a lifeguard and CPR, at that time it was, the breaths are utilized. And in your talk, they mentioned it's not required, might be good. With such a low perfusion rate, 40% kind of being the top end, do you think that if breaths are utilized, that it might improve any of these outcomes in brain injury or brain phenotype associated with CPR?
And this is speculation on my end. I'm sure it would. It would make sense that it would. The reason why rescue breaths are kind of optional is because of safety to the provider. Now, when you're in a hospital setting or a paramedic setting, first responder, they have bag valve mask apparatuses that they use, and so there's no direct mouth-to-mouth contact. But there have been enough cases of contact overdoses, such as somebody overdoses on fentanyl, and so they're trying to resuscitate, and then they go mouth to mouth and also overdose because of just the sheer amount of drugs ingested. There's also just the risk of communicable disease transfer. Now, in a lot of CPR classes, I mean, every time I get renewed, I get an additional one of these, but they have one-way valves. That's basically just like a sheet of plastic with a valve in the middle, and you put that on their mouth and you're able to safely go. But they do say that if you aren't able to do rescue breaths, continue doing CPR,
Sure.
continue doing chest compressions because it's better than nothing.
Yeah, it's too bad they didn't really look at that, especially on the out of hospital cohort part of this group. The folks who were started on CPR outside the hospital setting. If it was from paramedic or someone that could administer oxygen, either through breaths or however, versus those who didn't, getting a good comparison would, in my opinion, strengthen the study a little bit because, you get a lot of these outcomes probably based upon, as you said, lack of flow, which is basically lack of oxygen to the brain. So,
yeah, I believe that's another limitation. When I was trying to think of other limitations for the study, I thought of similar. It's hypoxia, and we don't have a whole lot of extra details about that. But I didn't even think about whether or not ventilation was used.
mm-hmm.
I was wondering if they're in their review or discussion, they had referenced any studies by the American Heart Association, because they're doing frequent data analyses from a large representative pool of cases that they use to update their recommendations for, how many compressions to breaths, et cetera. As Dr. Creamer mentioned, in recent years, they now recommend or say that compressions are more likely to improve outcomes than breaths, for example. So I was wondering, did they talk about in their discussion section any comparative data from their study, which is a limited sample, to American Heart Association studies?
No, unfortunately, they didn't. A lot of the data prior to arriving to the hospital, or they really looked at more of the outcomes, not really how that affects the prior recommendations. They didn't make any comparisons between them and the AHA or the Cardiology Association.
To my next meeting, and thank you so much. I really appreciated your presentation.
Thank you, Dr. Gordon.
I'm
Dr.
so
Johnston,
sorry.
do you have
I showed
a
up
quick question?
over halfway late and I missed it. Where is it published?
It was published in a journal called Resuscitation. I think it was called Resuscitation. Yeah, Resuscitation. It was published this July. And it was authored by the people out of the University of Pittsburgh.
I see. Was the and again, I apologize for showing up late and I don't deserve an answer on this one, but were these just garden variety heart attacks, or were these fentanyl related, or what's this clinical setting?
They didn't include any cause of the arrest. They only excluded neurological causes and traumatic. So that could include any drug-induced heart failure or anything. They were more looking at outcomes of the arrest and how that correlated with their respective brain injury.
And did they give you a downtime estimate of how long the patient had been in arrest?
Yes, they do. So while there is some missing data, they do have, here is a pretty good graph showing it all. So in this category, which is those who were awake after the resuscitation, I believe the average is about 6 minutes of CPR. Then it jumps up to around, I believe it was 15 or so for the coma category. Then there's a EEG phenotype that's pretty specific to cardiac arrest.
Okay.
That was in the late teens, early 20s, and then finally cerebral edema, which was the most severe, had the longest average.
Sure. Well, you brought back some old drugs that I didn't realize were still in usage, relevant to mannitol. Very rarely did we ever give it. And hypertonic saline, the tonicity of hypertonic saline, it's got something like, how many milliequivalents of sodium and chloride are in hypertonic saline? I'm asking you.
I don't know off the top of my head, no.
You should, because if you're going to reference it, you need to know that the osmolality is quite high, but look it up. There's a lot. Normal saline has got 154 milliequivalents of sodium and chloride. So hypertonic is about 3 times that. But it is a bunch.
Okay.
Sorry I missed that one, Dr. Kramer.
Hey, no problem. That was on my end. Not getting the info out well enough. And
no, I just walked in late from meeting, so I apologize. Sounds like student Dr. Reagen, you're all on top of this. I wish I could have heard it all.
Oh, I appreciate it.
Well, we'll make the recording available, Dr.
All
Johnston, and so if you would like, go back and watch that. So
I appreciate it. Thank you,
Student
sir.
Dr. Reagen, thank you again for presenting for us today, and we will get you a copy of the recording or a link to the recording probably in the next week or so as Dr. Staudinger transfers it over to YouTube.
Okay. Well, thank you very much.
All right. Have a wonderful rest of your day.
You too.